Our first speaker today is Professor Martin Hagger. Martin is a John Curtin Distinguished Professor and Founding Director of the Health Psychology and Behavioral Medicine Research Group in the School of Psychology, Curtin University, Perth, Australia. It was a very long, and it's not the end of the sentence. And Finland, Distinguished Professor Fellowship with the Faculty of Sport and Health Sciences, University of, maybe you help me? Jyväskylä, okay, in Finland. You should have seen how it's written here. It's completely different. He's also editor-in-chief of Health Psychology Review and Stress and Health, and editorial board member of 10 other international peer-reviewed journals. His research focuses on the social processes involved in self-regulation of health behavior, and it applies and integrates social, cognitive, and motivational theories to understand and to intervene and change a range of health behaviors. Today, he is talking about health behavior, health promotion, and the transition to parenthood, insights from research in behavioral medicine and health behavioral change. Please welcome Professor Hagger.
Fantastic. Thank you. Hello, Tel Aviv. Thank you very much. Thank you very much for that very nice and warm introduction. And thank you very much to Orit and to Shirley and Miriam, all the people who have made this event possible. I've learned a lot, and it's not an area. I must confess, like many others, this is not an area, typical area of research of mine. And so I've learned a lot from listening to the presentations and the talks that have been given so far during this conference. So thank you very much for the invitation. So I'm going to be talking a little bit today about health behavior, health promotion, and applying that to the transition to parenthood. I owe a great debt to Kyra Hamilton, who is my co-author on the chapter that we submitted for the book that is accompanying this symposium. So yes, I'm originally from the UK, but I made the jump over to Australia 7 years ago. This is Curtin University in the wild west of Australia. It's in Perth, which is reportedly one of the most isolated cities in the world. And here you can see some images of the university and the students in their natural environment. And as Orit mentioned, if I get sick of the sun in Curtin, then I can always go to Jyväskylä, and I spend 3 months of the year there. And this is a typical vista of Jyväskylä University, and you can see a very different climate. So yes, I'm going to be talking a little bit about health behavior today. This is an overview of some of the things I'm going to be hopefully touching upon and get to during the course of my presentation. And so I'm going to be talking a little bit about the importance of health behavior in the transition to parenthood. I'm going to be talking a little bit about promoting health amongst new parents, but I'm also going to be talking about what parents can do to promote the health of their children, what I've called parent-for-child behaviors. I'm going to talk a little bit about psychological theory, particularly social psychological theory. I'm a social psychologist, an applied social psychologist, so I'll be talking about things like social cognitive theories and how beliefs impact on people's behavior. And also I'll talk about another sort of class of theories which have extended these social cognitive theories, known as dual process theories, and planning as well, as additional factors that might impact on people's behavior. And then I'm going to talk a little bit about how that can be used, how that information, that research, that evidence can be used to leverage effective health behavior change interventions within parents and also their children. And I'm going to talk a little bit about behavior change methods and give some examples, some interventions in action, the kinds of things that we can do as people who are interested in promoting health to change behavior. And then I'll summarize and open the floor for questions. Okay, so we all know of the positive aspects of becoming a parent, the joys involved, but it's also a period of extreme change, and also can be quite stressful. So new parents experience things like loss of sleep, increased workload, demands on time, limited, less leisure time and downtime, restrictions on socializing with their partner, balancing work, family, social commitments, and expecting parents and new parents can fall out of the kinds of behaviors that would be health promoting. And that means that people are therefore more at risk, maybe more at risk of some of the more chronic diseases which are associated with low levels or with particular health-related behaviors. And I think this sort of summarizes much of the epidemiological research associating different kinds of health behaviors with reduced risk of chronic illness. So engaging in a suite of 4 key health-related behaviors, so not smoking, eating a healthy diet, participating in sufficient physical activity, and drinking alcohol only in moderation, is associated with an estimated 11 to 14-year-old delay in all-cause mortality, and reduced risk from those chronic diseases that I put up earlier, so cardiovascular disease, certain cancers, diabetes, and so on. So those are the risks associated with parents not doing those kinds of behaviors, or falling out of those kinds of behaviors during the transition to parenthood. So just as for looking at physical activity as an example, so research has demonstrated that parents of dependent children are less active than their non-parent counterparts. And regular physical activity obviously has these numerous health benefits, offering protection from certain illnesses, but it also is associated with positive mental health as well. And it also has positive effects on parenting practice. So it gives parents increased confidence in performing their parental role. There's also a positive relationship or an association between parent and child physical activity. So children do model their parents in terms of the activities that they do, and also parents are gatekeepers in terms, particularly for young children, gatekeepers in terms of participating in regular physical activity. And importantly, activity habits is fairly good evidence to demonstrate that activity habits are difficult to re-establish once people have fallen out of those health behaviors. And then, of course, the parent, a new parent particularly, has this ethic of care for their child. And obviously they need to offer basic safety and protection of the child, engagement in the prevention of illness, engaging in everyday caregiving behaviors, those kinds of things. But there are also other important behaviors that need to be promoted amongst parents. So engaging in immunization programs, extending breastfeeding, which is associated with reduced metabolic syndrome and so forth later in life for the child. Regular health checkups, oral health, and then as the child grows older, introducing solid foods, sun protections, key health behavior in Australia, and I know it's an issue here as well. And then again later on still, things like eating fruit and vegetables, limiting discretionary choices, snacks and that sort of thing. And parents are important in terms of socializing children into healthy habits. So diet and physical activity, stress and anxiety management, limiting things like screen time, sedentary types of behaviors in favor of active behaviors, personal hygiene, oral and dental health, and sexual health, for example. So in terms of just one particular behavior for children, regular physical activity in children offers protection against those kinds of chronic illnesses and antecedents of chronic illness later in life. And establishing physical activity patterns early in life will foster health benefits across the life course. And so there's fairly reasonable evidence demonstrating tracking of physical activity into adulthood. And few children have, in developed countries are actually sufficiently active according to physical activity guidelines in each of those nations. And parental support is a consistent correlate of child physical activity, leaving interventions for parents for their children's physical activity as a key network, existing network, that we can leverage to try and promote physical activity in children. And so that may be a means we can do by which we can do that. So how can health psychology, applied social psychology, help? Well, one of the aims of health psychologists is to identify the factors that might be reliably associated with health-related behavior. And these include personal, social, but also environmental correlates. And today I'm going to be mainly focusing on the sort of personal, psychosocial factors that are associated. And if we can identify those factors, and if those factors can be changed, are manipulable through some sort of technique or method, then we should be able to reliably change behavior. And they could be, therefore, targets for behavioral interventions. And so that can therefore provide us with evidence or information for behavior change interventions, how we can go about changing behavior, which is relevant for practice and translation. So why is psychological theory important? So a lot of people would say, you should be using theory, but a lot of people sort of give lip service to using theory when conducting research in this space, but often they sort of fail to see the relevance of theory. And for me, it sort of answers two key questions. It answers the what in terms of the factors that might be impacting on health-related behaviors, but it also helps us to identify how those factors impact on behavior, the processes and mechanisms responsible. And then hopefully, therefore, we can derive the kinds of factors and processes that we can tap into when it comes to intervention. And those theories can therefore facilitate our understanding, but it also means we can then modify our ideas, replicate them, and demonstrate how they might be applicable across multiple health behaviors, multiple contexts, populations, and so forth. So a lot of health psychologists have in mind this very sort of basic process model of behavioral interventions. So those factors that I just sort of talked about, those psychological factors, are assumed to be related to physical activity or other health-related behaviors. And if we can find those links, then some sort of change in these factors should result in some sort of concomitant change in the health behavior. And what we should be able to do then is identify, if we assume that these are manipulable, identify some sort of behavior change technique or method that we can use to change those factors. Okay, and therefore these factors become mediators of behavior change interventions. And then if people engage in those physical activities or other health behaviors over a period of time, then that should really relate to those health benefits that I talked about earlier, reduced risk from illness, positive mental health, and so forth. Now, most psychologists, social psychologists especially, are very fond of these box and arrow diagrams. Okay, you're going to be seeing a lot of these. And all they do is they reflect our ideas about systems, about how certain factors might impact on behavior, the processes involved. And so these factors are really just, they represent, I suppose, on an empirical level, they represent measures, usually through psychometric instruments, of those constructs. So it captures the essence of those psychological constructs. And then the behavioral measure will be some sort of measure of behavior. Usually there's some sort of time lag between those measures of the psychological constructs and the behavior, so that we can understand how they impact and explain behavior in the future. So this is a very prototypical social cognitive model. It's the theory of planned behavior. And that suggests that the most proximal influence on health behavior is people's stated intentional. It's a motivational factor, their motivation to do the behavior in future. And intentions are a function of personal beliefs about doing the behavior, whether they think that doing the behavior is a good thing to do, whether it will result in outcomes that are of benefit to the person, to the individual. And that's underpinned by sets of sort of behavioral beliefs. Subjective norms, so these are beliefs about significant others, whether significant others want you to do that particular behavior, and there's sets of normative beliefs that determine that. and control-related beliefs. So this is very much akin to Bandura's self-efficacy factor, so it focuses on whether people believe that they can participate in that behavior, and that's underpinned by control beliefs. And there's sort of pretty good evidence supporting this theory across multiple health contexts, including parental behaviors. So this is a meta-analysis that was relatively recently published, demonstrating small to medium-sized effects amongst the constructs, and those ranges vary according to the types of behavior under scrutiny. So these data demonstrate the efficacy of these kinds of theories. And in terms of the transition to parenthood, so those behaviors that are health promoting amongst parents, and also the behaviors that parents can do to promote the health of their child, you can see that there's sort of quite a lot of evidence now demonstrating the importance or the utility of the theory in predicting and understanding these kinds of health behaviors using the theory of planned behavior. So physical activity during pregnancy, smoking cessation for parents, and healthy eating amongst parents themselves. And then these parent-for-child behaviors, things like sun safety behavior, breastfeeding, introducing solids, eating healthily, limiting screen time, physical activity promotion, and improving oral health. So all of those health behaviors have been demonstrated to be predicted using these particular theories or models. And here's an example from some research we conducted recently looking at childhood sun safety. And this identifies the sort of salient beliefs, the most frequently cited beliefs that parents give for performing or not performing that behavior. So that's an adaptive behavioral belief, believing that engaging in sun behaviors for their child, so this is using sunscreen, putting on sun hats, wearing t-shirts and protective clothing, provides them with peace of mind against the negative outcomes of exposure to the sun, but it also it requires time, energy, planning, that kind of thing. Important people who would want them to do those behaviors, and the kinds of things that might get in the way or facilitate. So lack of accessibility, having a rule in place. Those are facilitative and factors which might be barriers to those kinds of behaviors. So we can put these in. It's not just the barriers or the beliefs, it's also the value that people attach to those beliefs. So you can use an expectancy value framework to come up with someone's overall attitude for a particular belief. And so this represents a behavioral belief, and this represents the value that people attach to that belief, and you multiply them together. But if, in terms of analysis, you multiply them together to get people's overall attitude towards that. And then you would do that for multiple beliefs, and you'd get these the sum of expectancy value statements give a person's overall positive or negative belief for that particular behavior. And you could do the same for control beliefs. And you can see that people have, in this case, overall a positive behavioral belief or attitude, and positive perceptions of control, in this case for sun safety. So that's how beliefs can be used to try to understand, and also using the value of the beliefs to try to understand behavior. And these kinds of frameworks have been used in multiple health behaviors. Here's reducing screen time. These are the kinds of beliefs that parents have cited as reasons to promote reduction in screen time, the salient reference, and the kinds of barriers or facilitating factors. And of course, these are the kinds of beliefs that could be targeted if we can demonstrate that these are associated with attitudes, that they're associated with motivation or intentions amongst parents to reduce their child's screen time, and we know that that's reliably associated with participation in screen time or reduced participation in screen time, then if we change these beliefs, we should have this change in behavior. And these factors serve as mediators to explain why that might be the case. And I neglected to mention what screen time really entails. So that's basically reducing use of devices, use of laptop computers, those kinds of things, and also watching television, those kinds of things. And the idea is that if those behaviors are reduced, then they might be displacing, for example, physical activity behaviors. So if we reduce those behaviors, then children might engage in more active pastimes. And then the same applies to physical activity, and these are the kinds of adaptive outcomes, barriers or facilitating factors, salient reference that impact on parents' physical activity. Excuse the typo there. You can see the clear cut and paste error. Now, the theory of planned behavior is fairly useful, but there are problems. As you saw from the summary that I gave of meta-analyses of the use of the theory of planned behavior in health contexts, the associations are not as strong as we would like. And also, it doesn't tend to encompass all of the different factors that might impact on health behavior. And research has demonstrated that, particularly in the space of parenting, and parent-for-child behaviors, other constructs are important, such as role construction, parents' role construction. So this is the perceived role of the parent that leads them to behave according to their obligations to their child and consistent with their perceived standards attached to that role. And that's been associated with things like sun safety, screen time. Things like anticipated regret. So I'll feel bad if I don't do that particular behavior for my child. That's been demonstrated to be associated with intentions and behavior in breastfeeding, physical activity, and then moral norms. So doing the behavior is something that's responsible, it's a morally important thing to do, and that's some research, for example, on that is quitting smoking amongst mothers with infants, which obviously reduces exposure to secondhand smoke. Other problems with theory? Well, motivation may not be as sufficient in order to get people across the line when it comes to understanding these behaviors and getting them to do these behaviors. So many people have stated intentions to engage in these behaviors. They have a motive or desire to do so, but they fail to engage in those behaviors. And people have talked about the so-called intention behavior gap, and this basically means that associations between intentions and behavior are less than perfect. In other words, many people say they're going to do something, but they seldom follow up on those intentions. And there are a number of reasons why that might be. As an illustration, some very interesting research has demonstrated this, the prevalence of this so-called intention behavior gap, and they call inclined abstainers or unsuccessful intenders, people who have good intentions to do something and fail to do so. It's often, New Year's resolutions are a classic in this regard. People have very good intentions to change their behavior, but they don't follow up on them. So this is some interesting research from Rhodes and De Bruyne. They looked at people's intentions, stated intentions, to engage in physical activity, and then looked up whether they followed that up with actual physical activity subsequently. And of course there was a group of people, a substantial number of people, who were successful intenders. They said they were going to do something and they followed up on that in terms of their participation in physical activity. But then there's a fairly substantial proportion of people who said they were going to do something but failed to follow up on that. So these are so-called unsuccessful intenders, these inclined abstainers. Of course, there also is a hard core of people who don't have intentions, have no intention to change, and of course they don't change. You have this weird group of people who don't plan on changing, but they seem to do things anyway. That may be a methodological artifact. Suffice to say that this group seems to be a sort of potentially low-hanging fruit in terms of behavioural interventions. People who are motivated to change, they're interested in changing, they intend to change, but they're not going about doing so. So these may be useful targets for intervention if we're trying to get a large number of people to engage in these kinds of health behaviours. And one strategy that has been proposed is getting people to be good at planning. And Gollwitz has suggested that actually motivation is not enough, that actually you need to furnish your motives with plans, with specific scripts for action in order to convert those good intentions into actual behavior. And he calls them strong effects of simple plans, or if-then plans. It's basically linking a cue or a prompt with the intended action. So if a particular situation or location or time of day arises, then I will do particular behavior. And it doesn't change a person's intentions. These happen sort of in a post-intentional manner, but they strengthen the intention-behavior relationship. Now, my hunch is that these folk are pretty good at enacting. They're pretty good at planning. They're pretty good at following through on their intentions intuitively. So they're already good at planning. So it's these people who need the help in terms of their planning. These people perhaps need more help in terms of their motivation, let alone their planning. And so there's pretty good evidence for these plans. So here's a couple of meta-analyses. So this is for physical activity, demonstrating a small to medium-sized effect for the effects of implementation intentions on physical activity behaviors. And then we've recently done a meta-analysis for multiple health behaviors. And this is not just for parents and parent for child behaviors, but across multiple behavioral groups and multiple populations. And we find, again, this sort of small to medium-sized effect for implementation intentions. This is getting people who are already motivated engaging in the behavior itself through these planning interventions. I'll give you an idea of what they look like a little bit later. One of the other shortcomings of these kinds of social cognitive theories is that they don't encompass these more non-conscious, impulsive influences on people's behavior, things that occur in a more automatic fashion. And that's led to these sort of recent dual processes perspectives on health behavior. And the sort of typical, prototypical theory of planned behavior, those kinds of social cognitive models, tend to be focused on these reflective processes. So they tend to identify factors like attitudes, beliefs, and so forth that impact on people's motivation and impacts on their behavior. And these are reasoned, deliberative, weighing up of the positive and negative beliefs, reasons, rationale for doing the behavior. They're relatively slow, and they involve considerable cognitive processing. And this is to be juxtaposed with these more sort of, as I mentioned earlier, these are the sort of beliefs, norms, and so forth. And these are to be compared with these more sort of impulsive impacts, factors that impact on behavior in a more reflexive, automatic, non-conscious way. And they tend to be much more relating to feelings and affect. And so those may be represented by things like implicit attitudes and motives, habits, and so forth. And this makes sense because, life would be somewhat unbearable if we kind of weighed up the positive and negative benefits of every single action that we took. And so the impulsive influences on people's behavior is actually fairly adaptive. But it can also work against us. So as I mentioned before, bad habits are easy to get into, and good habits are easy to get out of. And so we need to try to understand these habitual factors and their impact on behavior. And we've demonstrated some of these kinds of effects. So here's some, again, from the Sun Safety study we conducted. Habits have a significant impact on parents engaging in these sun safety behaviors above and beyond intentions. And so it seems that for some people, these are healthy habits. So getting people into those healthy habits may be a useful way of promoting that behavior, and it may be a more reliable way of managing that behavior over a long period of time. So how can we use all of this information to change behavior? Well, health organizations are very keen on developing these kinds of behavioral interventions and promoting health amongst new parents. But many of these kinds of government-based interventions tend not to be based on a fundamental understanding of human behavior, tend not to be based on psychology, and that's not true. That's true for many interventions, not just for parents. And many interventions are also very poorly described. So if you look at the research evaluating behavioural interventions, they tend to be poorly described. They don't explain exactly what the content of the intervention was, how it was delivered, those kinds of things. And they've also demonstrated somewhat inconclusive findings. Some are very effective, others less so. But because the descriptions are so poor, we don't really know what's going on, why some of those interventions were effective and why others were less so. And interventions in health psychology, behavioral medicine, implementation science try to gain a clearer understanding of the factors that are associated with behavior and the effective components of interventions that are doing the work in terms of changing behavior. And the idea is also to systemize content and descriptions so that we have a sort of common vernacular or language to describe behavioral interventions. And they can also provide guidance for practitioners. It's a kind of what works and how approach. So what am I talking about when I talk about behavioral interventions? Well, they generally happen in the domain of public health, and the idea is to get people to engage in behaviors to prevent chronic illness long-term, and promote adaptive health. And so the aim is to promote adaptive health outcomes and also things like quality of life, reduce stress, those kinds of things. And interventions can use existing networks to reach a captive audience of people whose behavior we need to change. So there's some examples there. Schools, for example, households, family-type interventions are extremely effective in this space. And we can also use things like media and social media to deliver the interventions, but they can also be the content of what what practitioners say to clients in one-on-one situations. So the interventions, the sort of active content, the active ingredients, are instructions, information, demonstrations, prompts, exercises that get people to be more motivated and maybe intervene to change their psychology, change their beliefs. And there are a number of considerations that an interventionist has to take into account when trying to change behavior. What's the problem that necessitates change? Who needs to change? What's the target population? What behaviors need to change? So in this space, it's sort of fairly clear. It's parents and the kinds of behaviors we've identified before. What change mechanisms need to be activated? So those are the factors that I identified and how those factors impact on behavior. And what behavior change methods can be used to activate change. And that's what I'm going to focus on now. So again, this recalls this sort of basic process model for health behavior change interventions. So I'm now sort of focusing on this bit. We've identified those factors and the behaviors. So we're now identifying this bit. So what am I talking about when I talk about behavior change methods, techniques, strategies? Well, they're the so-called active ingredients of health behavior in change interventions. They're the ones that do the work when it comes to changing behavior. And there's a lot of research engaged in trying to identify the individual components, the irreducible and unique strategies that can be used. And these can be seen as the sort of tools in a toolbox of behavior change interventions. Now, many interventions actually use multiple strategies, multiple methods. So they can be used independently, but they're usually used in conjunction with others. So we have multiple strategies in one given intervention. And these have been best described in behavior change taxonomies. So these are structured organizations of these unique methods. And they've arisen due to the need for a common vocabulary for describing these kinds of interventions. And my analogy, it's kind of like mapping. It's very grandiose, but it's a mapping the genome of behavioral interventions. And so this is a very limited description of these kinds of taxonomies that I've produced, but it gives you the idea. So this is intervention content at the apex. These are the kinds of things that probably need to be changed, the factors or classes of factors that need to be changed. And down here, you have the kinds of behavior change methods. So if we want to change beliefs, then we provide people with general information about the link between doing the behavior and the outcomes. We could describe the consequences of doing or not doing the behavior. So maybe illustrating the risk involved, for example. If we wanted to promote self-efficacy, confidence, we could prompt mental rehearsal. We can set goals. We can provide people with successful experiences, which will give them confidence in doing the behavior in future, and so forth. So those are examples of the techniques we might use to target these different factors. So again, this is kind of a more elaborated version of that basic process model. So we have these methods, they should impact on our mediators, and we have the various health behaviors that might result from those changes. And so these are the kinds of targets we've identified in the previous literature that I presented to you that could be targets for behavioral interventions in terms of promoting parent or parent-for-child behaviors. So what I'm going to do now is give you some examples of how this kind of evidence and these kinds of strategies have been used in behavior change interventions. So here are a couple of strategies or techniques. So providing information on the behavior health link, describing the consequences of behavior. So one example of an intervention based on those kinds of methods or strategies would be using pamphlets or leaflets to identify the possible benefits, in this case of physical activity, to promote health. Okay, and here's my sort of, this is an illustration of some of the pamphlets that are available to change physical activity, which make those links between doing physical activity and the kinds of health benefits that one could gain as a parent. We can also illustrate risk. So here's a couple of factors aimed at changing attitudes, and they prompt, for example, prompting people's personal assessment of risk, emphasizing susceptibility in terms of the negative consequences of the behavior. So you could come up with something like a poster communicating that susceptibility. So this is an example from the Live Lighter campaign, demonstrating, doing the behavior and the kinds of consequences involved. And then, just plugging that into our sort of, process model. You've got the sort of information provision, changes in attitudes and risk perceptions as the mediator, and impact on health behavior. Another set of factors or strategies would be to change self-efficacy or increasing people's confidence for doing the behavior. And that might involve things like demonstrating the behavior, getting people to do the behavior, practice it successfully, always tends to increase confidence. So that might be instructing people to practice skills to monitor their behavior. And we have a number of different ways that we can do that. In fact, we have a multitude of these kinds of devices. We can go low-tech and use diaries, but we can also use these kinds of devices which give people the opportunity to monitor their progress and demonstrate success. Now, just giving people a device or a diary is not a panacea for behavior change. It doesn't work. There's good evidence on that. You can't just give a person a Fitbit and expect them to be active. If it was that easy, then I'd be out of a job. But actually, it's how people use these kinds of devices and giving people clear instructions on how they might demonstrate success using these devices and demonstrate progress using these devices that is key. And so they need to be used in conjunction with the practitioner. So that's illustrating that in terms of this process model. What about planning? So we can try to address that sort of intention behavior gap by using planning exercises. And this is what a typical if-then plan that I outlined to you earlier looks like. So for the sun safety behavior, if I'm taking my child outside for a regular walk in the park, so that's an event or a situation, a person is prompted to write down, there's my device telling me that I'm not active enough. And then I will apply a sunscreen and put on her hat and long sleeve clothing before going out. So basically, these very basic, simple plans are actually very effective in changing behavior, or at least promoting good conversion of these plans into actual behavior. We can also promote environmental change. So this is particularly where we can leverage changes in the environment and get people to change the environment themselves in order to promote behavior change. This is particularly where people have problems reducing or minimizing a particular behavior. For example, people who are eating unhealthily, the unhealthy food is the cue to engage in that behavior. So getting them to recognize that and also to put strategies in place to manage those cues to that behavior may be useful in terms of changing that behavior in the long term. And so fairly straightforward, easy intervention that people can do, remove that cue. And that's very much associated with these environmental structuring strategies that have become popular within governments and organizations. And they've been shown to be effective, but of course, they need to be accompanied by other things in order to result in long-term behavior change. But here we have, this notion of nudge, small changes in the environment resulting in large-scale changes at the population level in behavior. And they're very effective when people have bad habits, if you like. So it's structuring the environment, making the desired behavior the path of least resistance, the easy behavior, the easy alternative. Okay, so that's nicely illustrated in Nudge, Nobel Prize winning Richard Thaler and co-workers. So just to summarize, I've talked a little bit about the use of theory. I've identified the kinds of factors from social cognitive theories that might be important in terms of correlating with behavioral engagement in parents and for parent-for-child behaviors. I've talked a little bit about designing theory-based interventions, things like giving information, experiences of success, promoting self-efficacy, planning, environmental restructuring. These are all things that we can do to change behavior. And I've given some illustration of how they might be implemented in real-life contexts. Thank you very much for listening.